It was an honor to be the first chair of this forum. I'm very happy with, the progress we made. I'm very excited to see what Angel's going to lead us this year. I'm very happy to have Danielle as the vice chair. And I just want to thank Kirsten and Dawn for leading this session. I appreciate y'all.
And thank you to David and Nicholas.
Okay, I'll go ahead and introduce our speakers for tonight. This is our second FSHP Emergency Medicine Critical Care Forum. We're going to do two presentations, one on open fractures and the other on dual sequence defibrillation. Our presenters today is going to be David Taska. He's a pediatric clinical emergency medicine pharmacist at Nicholas Children's Hospital. And our second presenter will be Nick Scaturo, which is he is a pharmacy clinical specialist in emergency medicine at Sarasota. My name is Donald Johnson. I'm a pharmacist at UF Health Jacksonville, and I'm co-moderating with Kirsten Busey, a pharmacist, clinical pharmacist at Sarasota Memorial. I'm going to go ahead and turn it over to David Taska, who will be presenting on open fractures that we see within the emergency medicine and trauma centers.
Thank you. Real quick, Nick, did you want to go first?
Yeah, if you don't mind, David,
Yeah.
not to steal your thunder.
No.
Sorry about that.
Yeah, you go ahead.
All right. Thank y'all. I appreciate the introduction. Again, my name is Nick Scaturo. I am an EM clinical specialist here at Sarasota. I don't have any disclosure slide after this since it's not like an official CE event or anything, but I will disclose that I know very little about Star Wars despite the title slide here. So if you see me at FSHP or ASHP, please don't just quote Star Wars at me because I will not understand what you're saying. But somehow this quote here from Darth Sidious has stuck with me in the only Star Wars movie I've seen. This power, unlimited power. And it seemed to be pretty fitting for refractory ventricular arrhythmias and alternative defibrillation strategies that we're going to talk about today. So just a couple objectives to get through since it's a rather short presentation. We'll define refractory ventricular fibrillation or RVF, and then we'll examine the evidence and some operational considerations for dual sequential defibrillation or DSD, and also VC defibrillation, which is vector change during shockable cardiac arrests. Quickly, just some numbers to get through. We know there's around 400,000 sudden cardiac deaths in the United States each year. And about a quarter of those are going to present with an initial shockable rhythm, those being ventricular fibrillation or pulseless ventricular tachycardia. We also know that being pulseless is a bad thing, but being pulseless and being shockable is actually a good thing because this subset of patients tends to be more responsive to our resuscitative efforts, and that does also translate into higher neurologically intact survival rates. Unfortunately, this is a talk on refractory ventricular arrhythmias, which is actually a poor prognosticator. As one might imagine, for every shock that a patient does receive, their chance of 30-day survival does decrease. All right, so what am I talking about when I'm talking about refractory arrhythmias? Well, there's no guideline definition out there for refractory ventricular fibrillation. And in my opinion, it's actually a bit of a misnomer, right? When we're talking about refractory ventricular fibrillation, generally we're actually talking about both shockable rhythm types, VF and pulseless VTAC. It's said to occur after 3 standard defibrillation attempts, and those need to be separated by 2 minutes each. Some definitions that you look at are going to include drug administration in their definition, stating that the patient's got to receive at least 1 milligram of epinephrine and or have that first bolus dose of amiodarone at 300 milligrams. But for simplicity's sake, I really just think 3 shocks equals refractory. This is also thought to be a subset of electrical storm. Generally, the difference here is that patients with electrical storm have a pulse. These are patients with multiple ICD fires or persistent runs of monomorphic and polymorphic ventricular tachycardia. And although some of the pathophys can be shared between the arrhythmia types, the general difference, again, is that those patients have a pulse. All right, so here's just a visual representation of that definition and where you might consider a person in refractory VF if you're looking at the ACLS algorithm for shockable cardiac arrest patients. All right, so what about our standard of care practices? Why am I essentially going to say that these interventions aren't enough? Well, let's start with epinephrine, kind of our core ACLS medication. We know that in shockable arrest, the effect of epinephrine that we're looking for is alpha-1 agonism, because that increases coronary perfusion pressures, and that provides oxygen to those tissues that so desperately need it, that are ischemic, that are dying, and those increased coronary perfusion pressures have been linked with increases in return of spontaneous circulation, or ROSC. Unfortunately, that perceived benefit does come with some risks, most notably increased myocardial oxygen demand and increased arrhythmogenicity. Probably not the best risks you want to incur for your patient if they're currently experiencing a lethal arrhythmia. So in theory, that sounds bad, but let's quickly review some evidence and let's focus this on shockable rhythms. Most people are going to be familiar with this trial. Paramedic 2 explored over 8,000 patients with out-of-hospital cardiac arrest. They compared epinephrine to placebo, primary endpoint, survival at 30 days. Real simply, what did they find with their primary outcome? Well, in the total group of patients, they found a statistically significant increase in 30-day survival. Whether that's a meaningful outcome is a discussion for a different day. I'm not going to get into the weeds about meaningful outcomes in cardiac arrest literature, but that's what this study looked at. That's what they found. However, when you go and dig a little bit deeper, pull the supplementary material, what you'll notice in this purple box here is that that survival benefit was really driven by those with non-shockable initial rhythms. You'll see patients with initial shockable rhythms did not see a statistically significant increase in 30-day survival with epinephrine use. You can see that that odds ratio does cross 1. It's pretty close at 0.95, so maybe there's some clinical significance there, but this is a large RCT, and it's suggesting that there may not be a survival benefit with epinephrine in shockable rhythm cardiac arrest patients. So quick takeaways then, epinephrine does seem to increase survival in out-of-hospital cardiac arrest, but that does seem to be driven by non-shockable rhythms, and there may not be as much benefit to those who present with initial shockable rhythms, and certainly maybe not with refractory ventricular arrhythmias. All right, so what about our other pathway drugs, or drug in this case? I chose to just talk about amiodarone for time's sake. Spoiler alert, lidocaine, amiodarone have pretty much the same evidence despite a different mechanism of action, but let's look at amiodarone here. So the mechanism, it blocks potassium channels. That's its main cardiac effect, which makes sense. It increases the relative refractory period. It gives the heart essentially and the ventricles sometimes to reset and hopefully, reintroduce a perfusing normal rhythm. It also has multiple cardiac effects, as we know. It decreases automaticity through its work as a beta blocker and a calcium channel blocker in your SA and AV nodes. And that's been thought to help block catecholamine excess, which is also thought to be a driver in some of these refractory arrhythmia patients. Concerns with the medication would be bradycardia or low blood pressures. Generally, the negative effects of amiodarone don't seem to outweigh the benefits as we saw with epinephrine. But again, let's quickly kind of digest the evidence here. So there's 3 out-of-hospital cardiac arrest trials to really support amiodarone's use. The first is aptly named ARREST. It was published in 1999. Primary endpoint, survival to hospital admission, and they did find a statistically significant difference in that with amiodarone compared to placebo. However, they didn't find any difference in survival to discharge. In ALIVE, published in 2002, same exact type of trial, same exact endpoint as the primary endpoint. This time, the comparator was lidocaine with amiodarone. Again, they found a statistically significant difference in survival to hospital admission, but no difference in survival to discharge. So the last trial is probably the most cited when we're talking about amiodarone or lidocaine evidence, ROC-ALPS in 2016. They chose, in my opinion, a better primary outcome of survival to hospital discharge, although they did not see a difference in patients who received amio or lido compared to those who received placebo. They did find a statistically significant difference in that outcome when they had patients with a witnessed arrest who received the study drugs compared to placebo. But unfortunately, there's never been anything to suggest that there's a difference in neurologically intact survival with any antiarrhythmic use in shockable cardiac arrest. So quick take homes. Amio or lido, They might improve survival if they're given early in the resuscitation course or if the arrest is witnessed, but they're unlikely to provide much more benefit than that. Hence, they don't improve neurologic outcomes in patients or haven't been proven to improve neurologically intact survival. All right, so we've gotten through that. We're kind of here at this part of the ACLS algorithm. We have a refractory ventricular fibrillation patient. We're repeatedly performing these unsuccessful measures, and they really do have little data to suggest that anything that we're going to do at this point is going to benefit the patient, unless, of course, we can find a cause of arrest. So I'll pause for a minute and grab some water, and I'll let Albert Einstein kind of tell you what I think about doing that. All right, so now I present to you maybe a solution to end kind of that insane ACLS practice for ventricular arrhythmia patient or refractory ventricular arrhythmia patients. I introduce vector change and dual sequential defibrillation. So VC defibrillation is as simple as taking the pads from whatever orientation you currently have them in. Usually they're in the anterolateral positions because you don't have to manipulate the patient or move them at all to place the pads there. And then you put them in the other standard position. So if they're in anterolateral, you move them to anterior posterior. DSD means taking an entirely new set of pads and a second defibrillator and placing them in whatever standard position has open real estate. Again, if they're in the anterolateral position, you put the new set of pads in the anterior posterior position. So visually, this is what that looks like. Additionally, we're going to talk about the dose VF trial. But I will say that they have an excellent video embedded in the online publication in the New England Journal of Medicine to show how either of these processes kind of play out during a resuscitation attempt. So if you're curious at all, I would visit the publication and watch that video. All right, that was kind of the what, but what's the why behind these alternative defibrillation strategies? Well, for vector change, when the pads are placed in that anterolateral position, that specific way that the current directs through the body may actually miss the distal portion of the left ventricle as it kind of points backwards in the thoracic cavity and away from that direction of defibrillation. So if you change the plane, you might actually capture that portion of the ventricle where the arrhythmia is generating from and be able to terminate it. DSD has that exact same benefit as VC, as now the pads are providing currents across both of those planes. But there's also this increase in voltage. So defibrillators account for impedance or resistance, as you'll see it termed on the equation on the screen. But if for some reason the patient has a very large resistance or impedance due to mainly body habitus, we might need additional voltage or joules to overcome it. So you'll notice the equation, as I mentioned, this is Ohm's law. Current is the most important thing to defibrillate a patient, and current is voltage divided by resistance. Hence, if the denominator of this equation is large, you may need to increase the numerator to provide adequate current. I will disclose here that Physics 2 was the only class in undergraduate that I received a C in, but this is at least how I justify this, and it makes a little bit of sense to me. All right, again, in theory, all great, but what's the evidence? So this is a trial out of Canada from a very progressive EMS group, actually in Ontario, and they published what's termed the dose VF trial to shed some light on this practice. Prior to this getting published, it was really case reports, case series that dominated this kind of landscape. The evidence was really back and forth regarding whether there was benefit in DSD or maybe vector change was better. And there was also some serious concerns about publication bias, as you would think, people who had successful double sequential defibrillation attempts would be more apt to publish that than people who did not. So what is dose VF? Well, it was a 3-group cluster randomized controlled trial. The clusters were in 6 different paramedic agencies who crossed over to a different treatment arm every 6 months. They planned to enroll 310 patients in each group to power the study. COVID, unfortunately, had other plans, and they stopped enrollment early with just over a little over 100 in each group. Their aim was to compare the alternative defibrillation strategies of VC and DSD to a shared control, which was standard defibrillation in patients with RVF, and that was defined as a shock rhythm receiving 3 defibrillation attempts. Primary outcome of interest was survival to discharge. They also looked at arrhythmia termination, ROSC, and neurointact survival that they defined as a modified Rankin scale of less than or equal to 2. So focusing first on the outcomes for DSD compared to standard defibrillation, you'll see that all of the endpoints here are statistically significantly in favor of DSD. The primary outcome suggests a number needed to treat of 11. So for every 11 patients where DSD was used after the third shock, 1 would survive to hospital discharge. Pretty impressive findings. You'll also notice a statistically significant difference in neurointact survival, our most important cardiac arrest outcome. Switching over and looking at vector change compared to standard defibrillation, the numbers are slightly less impressive. You can see the primary outcome was statistically significant. However, that confidence interval is tucked as close to 1 as it could possibly be at 1.01. And the authors do note a fragility index in the vector change group of 1. And that means that, changing the outcome for a single patient in their primary outcome would have made the results not statistically significant. And that might say something, or maybe a lot of something, for a trial that's under-enrolled. Also, you'll notice that ROSC was not statistically significantly different between the groups, which makes this data a little bit harder to interpret. Generally, when you have increased survival, you have increased rates of ROSC, right? You're giving the patients an extra chance to survive, but we didn't see that here, which probably speaks to the frailty of the data as well. Safety. So they did have some safety outcomes in the trial, kind of an interesting endpoint to study, given the patient is currently maybe experiencing the worst safety endpoint imaginable, right? They're already experiencing mortality. However, what they looked at was damage to defibrillators during DSD, because this has been reported, at least in my knowledge, in just a single case report. And that would obviously be just, concerning if there was damage to the defibrillators, meaning that it would result in withholding potentially life-saving therapy for the patient if your subsequent shocks weren't going through and you didn't notice that the defibrillators weren't working, or if you couldn't replace those defibrillators immediately. So the trial tracked defibrillator damage, skin burns to patients, which can happen if you put the pads too close together and they are touching, or inadvertent shocking of personnel. And they actually reported 0 instances of any of these things happening. So naturally, in 2022, when this was published, the Twitterverse, I guess it was at that time, or maybe it's the Xverse now, well, they got a hold of this paper and it kind of spread like this wildfire of uncontained support for DSD. Like, this is something we absolutely have to do. And here's where I might just want to pump the brakes just a tad. So we recognize that this trial was stopped early. That's something I mentioned. And this generally does lead to an overestimation of benefit. The authors do well to note those fragility indexes of 1 in the vector change group and 9 in the DSD group. But we really wonder where those numbers might end up if the trial had enrolled the intended amount of patients. The study design here is good. It's not great. Blinding paramedics to the intervention would have been an extremely tall ask. I don't know how you blind someone. You put two sets of pads on every patient, but how do you blind someone to actually pushing the buttons? But it also could introduce experimenter bias, in my opinion, right? One paramedic group might be like, oh, awesome, we have this new double shock technology to resuscitate these patients. I'm going to really give it all I got to resuscitate this patient. Whereas in 6 months, when they changed over arms and they were in the standard defibrillation arm, they might think, well, there's really probably no use. We're just doing the same things over and over again. There's no use to try hard or prolong this resuscitation attempt. And that could obviously influence the outcomes. Lastly, there was a large number of protocol violations in the trial, and this is probably the most important point. This means that not everyone in the DSD or vector change groups actually received the intended treatments. The results that you see in the primary paper are presented as an intention to treat analysis, but when you look at the per protocol analysis of patients who actually received DSD or vector change compared to standard defibrillation, the numbers are much less impressive. You'll notice at the table at the bottom of the slide that now there's no statistical significant difference for vector change defibrillation, and where that number needed to treat was 11 for the DSD compared to just standard defibrillation. That number is going to get a lot larger because that confidence interval has now shrunk quite a bit. So it's probably more in the 20 to 30 range, but they didn't provide the raw numbers in this table, so I couldn't do that calculation. So quick takeaways here. We've implemented DSD into our practice because I think it makes sense to try something different when nothing's working. And there is some reasonable data to suggest that it may improve outcomes with limited risks to the patient and also the devices if you do it appropriately. However, I'd caution you that all that glitters is not gold. Not every patient you apply this to is it going to work for. And the data here that's presented is likely overstating the actual benefit of these therapies. So last slide for me. During the implementation of DSD at our institution, we did have to have some important discussions with both our EMS director and our Code Blue team. I know that Sarasota County is using DSD and also vector change defibrillation strategies for patients with refractory ventricular fibrillation. And I think it's important to talk with your medical directors or your EMS directors because it gives you a sense of what they're doing in the outpatient setting, what treatments they're going to receive. If they're doing DSD when they arrive at your door, are you going to continue with that DSD approach, or are you going to go back to standard defibrillation? If you receive the patient resuscitated after a DSD attempt, if they rearrest in the department, are you going to employ DSD to resuscitate them at that point? And then obviously there's some in-hospital Code Blue discussions that need to be held if you're going to think about using a DSD or vector change strategy. Probably the most important is if you go with DSD, you need to make sure that you have the availability of 2 defibrillators. This is probably readily available in an emergency department or a critical care setting, but maybe less available during floor codes. Staff education is also huge. One thing that's mentioned in the DOSE VF trial is that they had one paramedic control both defibrillators. This ensures that there's a short pause. You press one button, then you press the next button. You don't press the button simultaneously, and it gives one person control of doing that. Pressing the button at the same time could lead to increased rates of defibrillator damage. And then also pad placement is very key, making sure that the pads aren't touching for the risk of skin burns and fires and those types of things. One thing that we noticed, you'll see pictured on the mannequin there, is that we use the one-step pads because they provide data on depth and rate of compression. So we try to use those pads, but they're very large and bulky and take up a lot of real estate on the chest. So you couldn't get 2 sets of those pads on a patient. So we had to make sure we were stocking Pad Pro pads, a little bit smaller pads, so that we could do this without the pads touching. But ultimately, I think it's just important to have the important discussions with key stakeholders if you're thinking about implementing this process or are convinced by the evidence that I presented. So I'll end with this famous Star Wars quote that I found on Google that I've never heard before. My information is there. Feel free to email me if you have questions about our specific process or anything. I'm happy to take questions at the end of the presentations as well. Thank you, guys.
I appreciate that, Nick. That was a very interesting and very good presentation there. If anybody has questions, please feel free to put those questions in the chat and we can read them out. But Nick, one question that you kind of spur at the very end there was, what was the strategy of training and getting all this out and about, especially out of the ER and into like the critical care areas as well?
Yeah, so we really took a focus on nursing. We obviously educated our Code Blue pharmacists as well. But generally nurses man the defibrillators. So we took a focus on our Code Blue nurses, our ICU nurses, and our ECC nurses for education. We started running mock scenarios, mock codes to get them practice. Our nursing educators would kind of run mock codes during the day, just randomly grab some nurses and then have them practice DSD. Additionally to that, we didn't provide much education beyond that. The availability of defibrillators was a big thing as well. So luckily, we usually bring 2 code carts, a backup crash cart to any resuscitation attempt that occurs on the floor. So a defibrillator now travels with that second cart to make it available for DSD should they need it.
Hey, Nick, this is Kirsten. One question I had that I think may be of interest can you talk about the literature between using DSD compared to esmolol for patients with refractory VFib, and are you still using esmolol in your practice?
That's a great question. Yeah, so there's nothing. So I will say that our Sarasota County EMS protocol uses vector change in esmolol. That was kind of the decision that they made. I personally think that the literature is more robust. I think the dose VF trial, is much larger, even though it was under enrolled compared to those esmolol studies done by like Driver and Lee. So I tend to lean towards using an alternative defibrillation strategy over esmolol, just based on the robustness of the evidence that's currently out there. If you're talking from like a pathophysiology standpoint, I think esmolol makes sense for some patients as well. And sometimes I think it's a therapy that can be employed in conjunction with an alternative defibrillation strategy. It's never really been studied that way, except for a retrospective study that we did with our EMS protocol, but that did not find any difference between, the patients that were given our protocol versus the patients that were just received standard defibrillation, unfortunately. So kind of, I guess the jury's still out on which one might work better, but I think at this point in time, the evidence kind of points towards DSD or vector change, in my opinion.
Thank you so much. If anyone has any questions, again, please go ahead and put them in the chat. We can come back to any questions for Nick at the end of both presentations. But I think for now, we can move on to David.
All right. Can you all see that and hear me okay?
We can, David.
Okay. All right, let me just check one thing. All right. So as Don had mentioned previously, my name is David Taska. I am an emergency medicine clinical specialist at Nicholas Children's Hospital in Miami, Florida. Thank you all for FSHP to allow me to speak to you today about bug to the bone or antibiotics and open fractures. Full disclosure, Nick, I will step in if you do get any Star Wars references. I do love Star Wars, guilty pleasure. And caveat or a heads up that I do have just a couple of quick small questions just to make sure you guys are following. You don't need to answer them in the chat or anything, but you can kind of answer them to yourselves just to kind of brainstorm this material. So let me so I want you guys to picture this. Imagine that you are responding to a trauma where an individual gets into a car accident, they arrive at your trauma bay, and their humerus looks something like that. And you take one look at the patient and you say, oh man, that's bad. It usually doesn't take much of a brain to know when a fracture is a very bad fracture. So after initial assessment, the clinician diagnoses this patient with a grade 3 open fracture. Maybe get some pain control, they might get a tetanus shot. But really, the trauma team turns to you and says, hey, we need antibiotic recommendations. And so how we might best approach this patient from an antibiotic perspective is really going to be the basis of our short time here today. So I do have nothing to disclose. I know this isn't for CE, but I'll just put it out there. And hopefully by the end of this presentation, we can review the classification of open fractures, review what grades or types. I'll kind of be using those terms interchangeably. Which of those require prophylactic antibiotics. And then we're going to look at the advancements or what has been contributed to the literature for the management of open fractures from an antibiotic perspective, really since the guidelines were published. So just a quick background, what is an open fracture? In simple layman terms, it's any fracture that has some communication or communion with the outside environment. It can be as small as a puncture wound, or it can be as devastating as a traumatic amputation. About 3% of all of our fracture types are open fractures. And a big thing with these is about 1/3 of these patients do not have an isolated fracture injury. These patients come in with via a really bad car accident, a gunshot wound, and they have polytrauma that not only do we have to manage the fracture, but we also have to manage the other injuries that the patient currently has. Oh, sorry about that. So there are 3 types of open fractures, and we classify them according to the Scaturo classifications. And these are differentiated based on the wound length, the tissue damage around the wound, as well as the infection risk with that associated type. Type 1 being the most quote unquote benign, and type 3 being, oh my gosh, this patient looks, this is really bad, basically. So type 3 is really going to be the focus of our talk today. And these are classified by having a laceration or a wound of greater than 10 centimeters or a traumatic amputation. Now, type 3 can be further subclassified into 3 different types. We have type A, B, and C. And once again, these are all differentiated based on how much periosteal stripping there is of the bone, along with if there is any associated vascular injury. I wanted to just present this slide to give you a visual representation of what exactly we're dealing with and how physicians might classify these when a patient does arrive at your trauma bay. So starting on the left, we have type 1. These are our smallest open fractures. They have a laceration of less than a centimeter. Usually it's just a small puncture hole. And because of this, it's a minimal infection risk of about 0 to 2%. Type 2, we start to get a little bit bigger. So these are defined as a laceration anywhere from that 1 centimeter upwards of 10 centimeters. And thus, with a bigger laceration, you would expect a larger infection risk. And it has an infection risk of about 2 to 5%. But type 3s are really our major concern. And remember, these are the ones that have lacerations of at least 10 centimeters. So starting with type 3A, these are our most common of the type 3 fractures. And these carry an infection risk of about 5 to 10%. So a lot of our low energy gunshot wounds and farm injuries are going to be these type 3As. Type 3Bs, how they get differentiated from type 3As is there is more periosteal stripping of the bone compared to type 3As, and thus carries a little bit more of a contamination risk and a higher infection risk, usually as low as 10%, but can be as high as 50%. And then finally, type 3, these are our baddest of the bad. And it looks bad just looking at this picture. And then what I really want you to highlight is, or key in on, are those droplets of blood. And because in type 3C, to all other types of open fractures, now we have a vascular injury and we have vascular compromise, thus decreasing blood supply to that injury. And then thus with decreasing blood supply, we now have the highest infection risk, as low as 25%, but can still be as high as 50%. The good news is we do actually have some guidelines to help us manage these patients when they do arrive at our trauma bay. And these are from the Eastern Association for the Surgery of Trauma, or the EAST guidelines. They do provide us with level 1 and level 2 recommendations. And the nice thing about these guidelines is they're quite short. So they're very fit for a emergency-centric brain such as mine, which is I want to the point and get me the information and get out of there type of thing. And so they give us some level 1 recommendations, which includes, they recommend establishing gram-positive coverage for all types of open fractures. Doesn't matter type 1 through 3, we should be giving them gram-positive coverage. In our type 3 fractures, however, because of the previous studies where they saw more polymicrobes in those fractures, including gram-negative bugs, that we do need to add on gram-negative coverage for those. And then if there is any fecal contamination or clostridial, recommending a high-dose penicillin. And that fluoroquinolones offer no additional benefit to aminoglycosides. And that was done by a study by Pazankis et al., if I'm pronouncing that correctly. and that they found when treated with ciprofloxacin that they did not, in the grade 3 fractures, they had slower healing rates and actually had a higher infection rate compared to those that didn't get ciprofloxacin. Now, level 2, they do recommend that we continue these for at least 72 hours, at the very least 48 hours. But once that skin closure of that soft tissue is done, we should not be continuing these for longer than 24 hours past that, so whichever is sooner. And that once daily aminoglycoside regimens are safe and effective in these in type 2 and type 3 fractures. And they make no recommendation if to do the every 8 hours or the once a day. However, the thing about these guidelines is if you look down at the citation, they were last updated in 2011, published in 2009. So that kind of begs the question of, in at least the 12 years since then, what have we seen? But before we get to that, I am going to do our first checkpoint question of which of the following is true. Is it A, according to the Castillo classification, there are 4 types of type 3 open fractures? Is it B, all types of open fractures require prophylactic gram-negative coverage? C, gram-positive coverage is only recommended in type 3 fractures? Or D, in type 3 fractures, gram-negative coverage should be added? Hopefully this one shouldn't be too challenging, but it is D. So in those type 3, regardless of if it's A, B, or C, we should be adding on gram-negative coverage according to the guidelines. So we're going to shift topics now and try and focus on, well, what else has come out since those guidelines? So the first study that I'm going to present is on 3rd generation cephalosporins, and this was done by Rodriguez and colleagues, specifically with ceftriaxone. As many of you probably practice in your settings, tends to be our workhorse antibiotic in the emergency department. And this was a single center retrospective pre and post protocol study, I believe at the University of Michigan, of 174 patients and of all types of fractures. So they did not differentiate between grades 1 through 3. The pre-protocol group got cefazolin monotherapy for 48 hours or cefazolin plus gentamicin for 48 hours. So basically standard of care. The post-protocol groups, the cefazolin monotherapy stayed the same for our grades 1 and 2 fractures, but for our grade 3 fractures, instead of doing the combo of cefazolin plus gentamicin, they did ceftriaxone monotherapy for 48 hours. They looked at a few outcomes, one of them being aminoglycoside use, pre and post protocol. So hopefully what you can appreciate from this slide is there was a significant decrease in the utilization of aminoglycoside use following the implementation of ceftriaxone monotherapy. They looked at the rate of surgical site infections, to which they also found no difference. They then tried to correlate this with the injury severity index and also still found no difference. And they also looked at, was there any resistant rates or differences in resistant rates of our resistant organisms? So things such as MRSA, things such as Pseudomonas, or any bug that had a resistance to one of the pre-protocol medications. And they also found no difference between those groups. So basically what they found was that we could likely get away with utilizing ceftriaxone as our gram-negative coverage versus having to add on an aminoglycoside. Other cephalosporins have been looked at. This was an abstract that was published in via the Orthopedic Trauma Association's annual meeting. And this was done by Maxon and colleagues that looked at cefepime plus vancomycin. So this was a single center retrospective study of about 1,500 patients, once again, across all 3 types of open fractures. And some of the things they looked at were the infection rates amongst the grade 3 fractures themselves. And they did find that there was a significant difference between the groups that did get the cefepime plus vancomycin versus the cefazolin plus gentamicin. They looked at the rates of MRSA infections between the 2 groups, They found no difference here. And they too looked at the polymicrobial infection rate and found no difference. Now, I do want to point out that you might look at these percentages and think to yourself, well, that's almost, a 50% reduction. However, when you look at the actual numbers within each group, it kind of evened itself out. Other antibiotics have also been investigated. So piperacillin tazobactam has been looked at by a few groups, just presenting on one, but Redford and colleagues did look at it. This was a single center study in specifically grade 3 open fractures of 72 patients. And their primary outcome was the rate of surgical site infections at 1 year. So what they found was that there was no difference between the two groups. So when the group that did get piperacillin tazobactam did just as well as the cefazolin and gentamicin. They looked at the 30-day surgical site infection rate. They also found no difference there. And they looked at 1 year mortality between the groups on the data they did have follow-ups on and found no difference as well. Now, interestingly enough, as of late, there has been this shift away from and this question of, well, can we get away with broad gram-negative coverage to begin with? Can we just utilize cefazolin, which is already our antibiotic workhorse for our grade 1 and 2 fractures? Can we just use it for all 3 types? So Bankhead, Kendall, and colleagues did look at this, and this was once again, a single center study. Probably start to see the trend here on those of 126 grade 3 open fractures. Once again, cefazolin plus gentamicin or cefazolin monotherapy. They looked at things such as surgical site infection rate and found no difference. They also looked at acute kidney injury, and they did find that those that did not get the aminoglycoside, which we obviously all know that there is a nephrotoxicity associated with that, did have a lower injury incidence. However, I will say that they didn't report on any baseline serum creatinines or chronic kidney disease within these patients. And they also looked at hospital length of stay, and they found that this was not statistically significant, but the cefazolin group did spend 5 days less time in the hospital. So one could make the argument that those 5 less days or 5 less days of not having those costs, not having chance for another hospital-associated infection, and thus could be clinically significant, although it wasn't statistically significant. Other investigators that have also looked at this, the last one that I'll present on is by Patenwala and colleagues. And this one is nice because it actually is a multi-center study, albeit in 134 patients. But once again, all grade 3 open fractures. They were treated with cefazolin plus gentamicin or cefazolin monotherapy. And their primary outcome was the occurrence of infection at the fracture site, to which they found no difference. And then also they looked at acute kidney injury incidents, and they also found no difference there. So just kind of wrapping up, that leads me into my next question of, if the trauma team, let's say they do want gram-negative coverage, and which of the following may be those reasonable options? Is it A, gentamicin, B, ceftriaxone, C, piperacillin tazobactam, or D, all of the above? And hopefully the answer is D, all of the above. That's what you arrived at, albeit we are shifting away in recent evidence from gentamicin and aminoglycosides. As of current guidelines, it is still a reasonable option. So I do want to just wrap up. Antibiotic prophylaxis in these open fractures is still a bit of a gray area with a lot of sparse and low quality evidence. And first and foremost, we're really guided by outdated guidelines. A lot of institutions now are trying to go away from the aminoglycosides and utilizing these other agents, although the aminoglycosides still are a suitable option. So we do have other options available, but they are still a suitable option. But the choice of that antibiotic really is going to be dictated by the clinical situation that the patient might have found themselves in. For example, if the patient got in a car accident and they were found in a ditch or a pond, and now we're having to be concerned about things like Vibrio or Aeromonas, that might make me dictate my antibiotic choice from just, say, ceftriaxone. And finally, although it is controversial because it does go shift away from what the guidelines currently recommend, there is actually emerging evidence of doing away with that broad gram-negative coverage as a whole and really just utilizing cefazolin monotherapy for all three types of grades of open fractures, and it just being the sole workhorse. So that's really all I have for you guys. Thank you once again for letting me speak to the panel here. My contact information is there. I will gladly answer any Star Wars references that Nick might not be able to, or answer any questions about the material I went over today.
Hey, thank you, David, for presenting on this. In any of the papers that you went over, did they talk about going back and forth to the OR for washouts and skin closure and the duration of antibiotics that were they continued past that 48 or 72 hours in those situations which they kept on going back to the OR?
So that's a great question. There were patients that did go back and forth to the OR. I do not recall of any that would say that they continued those antibiotics, although, if the wound is, still having that kind of dishwater type of look and it's not clean to the edges, then there's certainly it's reasonable to continue those antibiotics as a whole. These studies are also hindered by things such as historical bias. So, for example, in the piperacillin tazobactam study, the antibiotic beads were still kind of the thing. But as wound vacs and stuff started to come out and we could get those wounds closed earlier, we started seeing a historical shift towards the wound vacs and away from those, which certainly could have influenced the data a little bit as well.
Thank you.
Hey, David, it's Kirsten. And again, anyone from the audience who has any questions, feel free to jump in or type anything you want in the chat. This is just meant for an open discussion. I had a comment and a question. My comment is that we have been attempting to get our open fracture protocol to move away from aminoglycosides now for about 6 months. It's not our trauma team that's pushing back. It's actually our ortho trauma team who has a lot of feelings about getting rid of their aminoglycosides. I'm just curious if anyone has completely shifted away from aminoglycosides or really broad spectrum negative coverage in their open fracture protocol.
Yeah, I can speak for UF. We have completely gone away from aminoglycoside and have swapped over to Rocephin for our open fractures, high grade open fractures. And I mean, pretty much in, conjunction with orthopedics and the trauma service to make that change, just to the fact that, aminoglycosides have a higher risk of kidney injury and all the other things that go along with them.
And Kirsten, I'll kind of touch on that from the PEDS perspective. Us too at Nicholas, we have shifted away from aminoglycosides for our gram-negative coverage, and like UF, we also utilize ceftriaxone for our broader, quote-unquote, broader gram-negative coverage.
Thank you. It's giving me more ammunition for the fight.
Happy to help.
Hey, David, I had a quick question for you, and also kind of to piggyback off the conversation at hand. Kind of like Kirsten was saying at my institution here at TMH, our trauma team is actually on board with a lot of this evidence, but it's actually the orthopedic group that's more pushing back on that. But then also the occasion that I've run into more than one time, unfortunately, is that the orthopedic side, they get really funny about the high dose penicillin and the for clostridial concern. But at your institution or at other institutions, do y'all have a way that y'all typically identify a concern for that? Typically, trauma patient comes in. If you get a report from the field, it's never typically as obvious as the person was found in a pond or something like that. It's normally pick them up on the side of the road. Don't really know the full story, but just curious if you might be able to speak to how y'all differentiate when you feel like the high dose penicillin is warranted in a patient.
Yeah, that's a good question. I kind of have a lower threshold of that. And the reason being is that I don't have like a straightforward answer to that, but it depends on my relationship to the clinician who's wanting it. If they know me really well, I might, try and push them away from it if I have a indicator that, I don't fully believe it. But also I kind of come back to, is it really going to hurt the patient? If these antibiotics, as long as it's not kept on for, a prolonged period of time, I think that's really the big kicker. If it's truly not going to hurt the patient, then, I might have a lower threshold of letting that through and just letting my clinical gestalt kind of take over. But unfortunately, it's not a very straightforward question or answer, excuse me.
I agree with David. At UF, it's we don't see it very often, but a lot of times, it's just how they present, and they comment about grass and mud and all that being in the wound is kind of how it, gets started.
Yeah, Don, I would agree with that too. A lot of it is just reports. I would say inland from Sarasota, we actually do have a fair amount of farming communities. And so we do actually see some of your more clear cut, like using farming equipment out in the field incidents. But we do also have just some, accidents where we kind of base it based on the debris in the wound. David, do you mind touching quickly on, also you mentioned your coverage of kind of your marine organisms, since we're in Florida and a lot of us are along the coast or near large bodies of water. Can you kind of describe what you guys use for that prophylaxis?
Yeah, that's a good question. So at our institution, we utilize piperacillin tazobactam. In peds, we do it at 112.5 mg per kilo. But I think it's certainly reasonable if you want to utilize cefepime. That'll cover a lot of your bugs as well. Your water bugs, excuse me. But at my specific institution, on our policy, it's piperacillin tazobactam.
Great, thank you. We've used Cipro and ceftriaxone for several years, but I think there's a lot of pluses to kind of the monotherapy approach. Did anyone else have any questions for